All right, good afternoon, everybody. Thank you. Sorry for the technical difficulties. I'm not sure what's happened. Sorry that I'm late here. So a little bit about me. I'm a uveitis specialist, but I was a comprehensive for about a dozen years. So I bring that perspective to our talk. So today I'm going to review 5 different cases to help general ophthalmologists identify serious ocular infections. A little bit about myself is I'm in a large multi-specialty ophthalmology practice in the western suburbs of Chicago. I previously came from Southern California, where I worked at KAISER PERMANENTE, as I had mentioned, as a comprehensive ophthalmologist. And then retrained and did a medical retina and uveitis fellowship at the NIH before relocating to Chicago. And I'm also at a VA 2 days a week with the residents. So on to my first case here. A 33-year-old female with a 1-week history of blurriness, redness, light sensitivity with pain in her left eye. She's a contact lens wearer and saw an eye care provider who did not see any infection or anterior uveitis, but had prescribed tobramycin. She returned back to clinic with more light sensitivity and was placed on Pred Forte 4 times a day in the left eye. On her exam, what's notable is in the left eye, she was 2400, had an elevated IOP. Her past medical history was significant for cold sores. During her 3rd trimester, she had a 5-month-old infant at home and was nursing, and she was an ID nurse in the outpatient setting. So this is actual photos of her anterior segment. You see large, greasy, stuck-on mutton fat KP in her left eye that went all the way up. And this is what her dilated exam looks like. You see multiple areas of retinal whitening with heme. There is almost 360 and arterial or attenuation. So the differential diagnosis is a viral necrotizing retinitis, aka ARN or acute retinal necrosis. Syphilis is always on the differential, and atypical toxo-retinochoroiditis. You want to consider CMV in an HIV or immunoincompetent patient, given the rapidity with which this happened in my particular patient. That was less likely, but is something you have to consider. And the amount of vitritis made that less likely. So the workup in this particular case, I did do an AC tap and I sent for PCR for HSV, VZV, CMV, and toxo. We did check syphilis, IgG, and quantiferon and just a basic metabolic panel. I did not check her for HIV, but that is something that you could consider in the right clinical scenario. So I'd like to point out that at this point, my working diagnosis was acute retinal necrosis, and I did not wait for the results of my TAP. I did treat her empirically, but it's always nice to have those results with you, but that should not stop you from treating. Her labs came back positive for positive quantiferon, and she did have serum antibodies for varicella, as well as for cold sores. This was IgG, so she's had past infection, not necessarily indicative of current infection. So this is a classic triad, as I had mentioned before: occlusive retinal arteritis, vitritis, and these multifocal white-yellow peripheral areas of retinal whitening. The treatment, there's different views on it. You can do an intravitreal versus IV versus PO. We had her in clinic, and this was actually the Friday before a long weekend, so we started her on oral high-dose acyclovir, but certainly you would not be wrong to do a IV antivirals. Sometimes the intravitreals take a couple of hours or days to get, so you want to get started on that. I've listed the different antiviral dosing. I tend to put patients on Valtrex, partly just because of my experience, but you wouldn't be wrong to start with acyclovir, famciclovir. So a little bit about ARN. It occurs in immunocompetent individuals, usually the 5th to 7th decade, but it can happen anytime. In general, it is a poor prognosis, with 50 to 75% of patients develop a retinal detachment. And prophylactic laser retinopexy does not affect the risk of retinal detachment. So we did not elect down the road to have her have laser. So post-treatment, this is what she looked like. She had only gotten oral Valtrex for a very long period of time at 2 grams TID. She did not have intravitreal. She actually was healing quite nicely, and you can see what the retina looked like. So the take-home message with this is that you always want to dilate a patient, even if you think it's only an anterior uveitis. It's a pan-uveitis until proven otherwise, and you always want to dilate the fellow eye at every visit because the risk of in the contralateral eye is still quite high. Okay, so case 2. I'm sorry that the audio isn't on the original talk here. So this is color fundus photographs of the left eye in a patient here. And I'll draw your attention here centrally where you will see this placoid lesion and this pseudohypopion with areas here of precipitates as well as the some arteriolar attenuation. Here's a fluorescein angiogram as well as a red-free. The red-free actually is what helped me make the diagnosis. You can see this large placoid-shaped lesion here in the fovea. So if you have access to photography, that could be very helpful. And indeed it was for me. I didn't initially know what this patient had. So this is a 57-year-old male with a 3-week history of painless loss of vision in his left eye that then progressed to the right eye. His only other, he did have another systemic diagnosis, which we will tell you about later. His visual acuity was 20/125 and 2200. His anterior chamber and his vitreous had mild cell. And this is what his retinal exam looked like. This is a different patient. And you can see this lesion here that encroaches into the macula as well as around the nerve. Similar lesion in the left eye. All the fluorescence is really helpful here to outline the lesions here in both eyes. And the fluorescein angiogram here does not show any leakage here initially, maybe a little bit of CME that may be developing. So this gentleman has ocular syphilis, and the diagnosis is one of a high clinical suspicion as well as serologic testing. So something you always want to keep in mind. And so over time, the way we test for syphilis has changed. It is done by syphilis IgG is the new paradigm from the CDC, where you first test for syphilis total antibody, and then if that is positive, there's a reflex testing that happens. So it's a good triage screen here to help us decide if an individual has syphilis and if it's a false positive. The treatment is penicillin. It is still the treatment of choice for all stages of syphilis. Acquired syphilis with ocular involvement should be treated as neurosyphilis with IV penicillin. The other thing you want to remember is that you can have a local reaction, and most uveitis specialists will treat this like toxoplasmosis. After 48 to 72 hours, you want to introduce some oral steroids because you can have more damage sometimes from the treatment because of the inflammatory cells. So this is what this gentleman looked like post-treatment. You can see on the left side, the lesion was quite visible, and here you can still just see the faint outline. And this is red-free here, which also shows the changes that happened after treatment. And the same thing here with the left eye. You can see pre-treatment and post-treatment. Autofluorescence is also very helpful here. And so this is the OCT, which is also very helpful at the level of the RPE. This granular lesions sometimes are a giveaway that you should put syphilis higher on your list. So syphilis is, as we know, caused by Treponema pallidum. It's a spiral-shaped bacteria or spirochete. It can be sexually transmitted or a congenital infection, and the only hosts are humans. The incidence of syphilis has been increasing. Currently, it does account for about 1 to 2% of all syphilis cases. It is a reportable infection, and you want to keep in mind risk factors are males who have sex with other males, HIV-infected individuals, and larger, more metropolitan urban cities. The different clinical stages, you have primary, where you have this painless papule that will ulcerate. It does tend to heal spontaneously, and it's very contagious. The secondary stage is many months later, and they're much more systemic symptoms, and you can have a macular rash. Latent syphilis is asymptomatic and not as contagious, and that can last many, many years. And tertiary syphilis is neurosyphilis. You can see some of these lesions on the hands. We don't shake hands anymore, especially in the era of COVID, but I actually had a patient who had these lesions on his hand, and I was grateful that I had not actually shaken his hand on that particular visit. So manifestations of syphilis is that, like I said, it was approximately 1% of patients who actually have syphilis. It's the great imitator, and it can affect every structure of the eye. The uveitis portion is by far the most frequent manifestation. It can present as an anterior uveitis, an intermediate uveitis, and can have various posterior manifestations, including a vitritis, a chorioretinitis as well. So always keep syphilis in mind when you see a patient. I always joke that if you're 2 or 102 in my clinic, you will be evaluated for syphilis. These two findings are very suggestive, those precipitates that I mentioned in the placoid lesion. Our third case is of a 31-year-old female from Sierra Leone. Past medical history was significant for hypertension and possible diabetes, and she came in with a chief complaint of floaters in her right eye for 1 month. Her vision in her right eye was 20/25, and her AC had 1+ cell and flare. The left eye is otherwise normal, but if you look at the right eye, you'll notice that she has 1 to 2+ vitreous haze, and it's the blood vessels are a little bit difficult to appreciate all the way through. If you look in the periphery, you will see that she has this white area of retinal whitening, and there's some suggestion that there might be some scarring that's there. And so when you hear that term of a area of retinal whitening adjacent to a scar, that should make you think of a certain diagnosis. This is her fluorescein angiogram, and you can see some late staining and some leakage as well with that lesion there. And she does have some vessel leakage there where I have the blue arrows there as well. So the differential is very similar to the first case I presented, toxoviral retinitis, as well as syphilis, the classic things that we should consider when you see an area of retinal whitening. So a little bit about interventions for toxoplasmosis is that depending upon where the lesion is, not every case of toxoplasmosis needs to be treated. There are some guidelines from the Academy. So if it's in the periphery or if there's not a lot of haze, some people will elect to monitor. I tend to be a treater, and I always offer all of my patients treatment, but certainly in certain clinical scenarios, you would not be wrong to monitor them. The lesion I had shown you before shows that this was likely a recurrence because she did have an area of peripheral scarring, so this was likely a reactivation adjacent to her previous location, and she may not have been aware of that first episode, which is not uncommon. So the other interesting thing with toxoplasmosis is the discussion about the long-term effects of intermittent treatment for recurrences is an area of debate. There isn't a consensus on when we should offer our patients prophylactic treatment. For me personally, if a patient has a recurrence after one episode, I have that discussion with them. I also talked to them at the initial time of presentation about the risk of there being a recurrence, but leave that ultimate decision up to them. For the most part, patients tend to be on Bactrim Monday, Wednesday, Friday. So this was the original lesion. This patient elected to be treated with oral Bactrim. And you can see the area here in the periphery has less haze and is starting to heal and scar down. And here's a close-up as well. And this is in comparison to when she presented. Toxoplasmosis is an infection with the protozoan parasite Toxoplasma gondii. It's an obligate intracellular parasite. It was first described by two independent investigators, one in Brazil and one in Tunisia. According to the CDC, 22% of the population over 12 years of age in the US has been infected. It's much more frequent in other areas of the world. So it's important to ask your patients where they were born or where they have traveled, because that can certainly put that higher on your differential. Typically is foodborne from eating undercooked meat or consuming water or food contaminated with feces from cats. The eye manifestations are less than 2% of individuals infected after birth develop ocular lesions, and the most frequent cause is posterior uveitis. And this patient that I had shown you has a classic manifestation with a dense vitritis of a headlight in the fog. So you really want to keep that in mind. The pigmented scar can also be a telltale sign to consider a toxo. So I had a patient who came in who said all she kept seeing was floaters and mists. She's a 71-year-old female who presented for an exam with me for a third or fourth opinion. She had seen floaters for quite some time and had seen a number of different ophthalmologists who diagnosed her with PVDs. Her ocular history was otherwise uneventful, cataract surgery, and her past medical history was significant for rheumatoid arthritis, and she was on systemic medications for her rheumatoid with Areva and Orencia. And so this is what her exam looked like. You can see that on these Optos photos that it's a very foggy image. There's quite a bit of haze. She has some mild blood vessel attenuation. And she had a similar picture in her other eye. And what was impressive about this patient's examination is that she had a little bit of vitreous cell in both eyes and some vitreous debris, but the amount of haze that she has was out of proportion to the amount of cells that she had. And I think that probably comes through in these photos. So when I saw her, I had I was very concerned that she had a particular diagnosis. Um, and what makes this diagnosis very challenging in this particular patient population is that they present with symptoms that mimic other diseases. They can be very benign, such as floaters or blurry vision. And as the disease progresses, it's hard to differentiate it from a uveitic inflammatory response versus something much more concerning, like a malignancy. So something you always want to keep in the back of your mind. So this is not from my patient because we went down a different route with her, but these are pictures of a similar diagnosis. And what you can see is this stippling here on the autofluorescence and on the OCT at the level of the RPE. So this patient had PIOL. I had sent her for a diagnostic vitrectomy because I was very worried that she had PIOL, and she had a vitrectomy, which did show that she had a B-cell lymphoma. Things that you want to keep in mind is that the view is hazier than would be expected. When you think of chronic uveitis patients, it should be on the top of your differential. A high index of suspicion is needed for ocular inflammation that does not respond to steroids or in persistent uveitis with individuals over the age of 80, as well as patients who are on immunosuppression. So my last and final case is a patient that I actually saw in fellowship. Was a young 35-year-old male with an anterior uveitis in the left eye. He had had bilateral cataract surgery and continued to have inflammation despite being on Durezol QID. He had a workup done, which subsequently showed that he had HLA-B27. And his history shows that he was a steroid responder. At the time I saw him in, his vision was 20/100, and we'll show you some pictures here of his anterior chamber. So he has a multifocal IOL in his right eye and as well as left eye. This is a dilated exam, and you can tell that he does not dilate very well. And in his inferior cornea, he has a number of white precipitates there. Didn't get a great view on his fundus exam, and so it was with the optos. And so the differential diagnosis with unilateral disease after cataract surgery, HLA-B27 was certainly on there, herpetic, sarcoid, lens-induced, a postoperative endophthalmitis, syphilis, and TB is always on there. So we'd gotten his old records when we had seen him and looked at the workup, and so based upon that, we had started him on methotrexate, and that didn't work. He was placed on Cellcept, had some improvement after 2 months, and we were still playing around with his eye drops to get improvement in his vision. But despite medications that we put him on, he continued to have ongoing inflammation. And so when we saw him, he still had KP. There's some issues with his compliance with Cellcept. He had been taking it incorrectly. So he came back to us in October, and he was compliant with his medicines. He was on prednisone 10 milligrams, Cellcept, and methotrexate, and this is what he looked like. And it was at this point that I was really concerned that he had an infection. His vision had decreased, and he had these large chorotic precipitates all the way through the course of his cornea, all the way up, and this is a close-up there. So we did an AC tap, and cultures were sent, and he came back and it grew back P. acnes. He did not want to have his lens removed at the time, so he received 2 rounds of intravitreal vancomycin and clindamycin, and there's some data out of the European literature that oral clarithromycin can be helpful. So we did that for a couple of weeks, and you can see that he had some improvement. Ultimately, we were not able to treat him locally with intravitreals, and he required surgical removal of his IOL. So P. acnes is classically thought of as a white plaque on the posterior capsule of the IOL. It can occur as early as 2 days. When I wrote this slide, the longest I had seen was a few years, but recently there's been a case report of somebody 17 years post-op who had P. acnes. So you always want to keep an open mind. You want to think of inflammatory causes and infectious causes and masqueraders. Some aspects that can be suggestive of an infection or acute presentation, unilateral disease, as well as an immunocompromised patient. Missing a diagnosis of infection and treating with steroids or immunosuppressives can sometimes worsen the condition. So you want to keep that in mind.